Welcome to the WPS GHA Contractor Advisory Committee meeting. Today is the 27th of June, and it is now 5:04 p.m. in the afternoon Central Time. My name is Mark Brady, and I am co-chairing this meeting for a short while. I'm from the state of Kansas. I'm an anesthesiologist, and my co-chair is Dr. Nikotsky. She is the J5, J8 Contractor Medical Director. Typically, we've tried to co-chair the entire meeting, but I had an unexpected family obligation come up, so I'm going to get the meeting started, and then Dr. Nikotsky will take over after just a bit. So I appreciate her doing that. And Richard, thank you for your help on putting this together. For disclosure requirements, the purpose of the CAC is to present the draft LCDs up for consideration and to take comments from the CAC. The public is welcome to attend in a listen-only capacity. Now the disclosure requirements per the 21st Century Cures Act. Your attendance as a CAC member at this meeting implies that you consent to the public disclosure of your opinion and agree that it may be used and will be clearly identified as your opinion within the proposed or final draft LCDs discussed. If a CAC member does not consent, please disconnect now. The meeting is being recorded and transcribed. To aid in transcription before you make any comments, please state your name and any conflicts of interest you may have, or state that there are none. Individuals wishing to comment may click on the raised hand icon. Press *3 if you are attending by phone. When Mr. Staley calls on you, please make sure that your microphone is on at your end and that your speakers are silenced to prevent an echo. CAC members should follow up any verbal comments in writing to the email address that's listed on the slide at the bottom, policycomments@wpsic.com or Medicare policy comments at wpsic.com. I'll now hand the meeting over to Dr. Nikotsky.
Thank you so much, Dr. Brady, for your introduction and participating. And I know that other commitments are important, and I hope that everything goes well over there. When you have to sign off, just please do. But in advance, thank you for meeting with me and willing to volunteer to co-chair tonight. At this time, I will be doing the presentation of the draft LCDs, which is part of our open meeting. I'm privileged to be accompanied by my fellow colleague CMDs, Drs. Claudia Campos, Dr. Juan Shaning, and Dr. Joelle Velazquez. As lead CMDs for their respective proposed draft LCDs, they will provide the summary of the pertinent data prior to any of the open comments. Tonight, there are 6 draft LCDs for this CAC meeting. Please note that there are 2 open comment periods. For attendees who are participating via phone or dial-in and who do not have webinar access at this meeting, I'm just going to state for audio communication these proposed drafts. So the first 5 drafts that I list in numerical order, their open comment period is from May 30th through July 14th, 2024. In numerical order, number 1 is DL39905. This is for cataract surgery. Number 2 is DL39907. This is for microinvasive glaucoma surgery or MIGS. Number 3, DL39909. This is for the botulinum toxin injections proposed LCD. Number 4 is DL39911, total joint arthroplasty. And then DL39913, artificial intelligence or AI-enabled CT-based quantitative coronary topography. That's AI QCT, and AI QCPA, which is coronary plaque analysis. The second open comment period is from June 6th through July 20th, 2024. and that is for draft DL 39051, the cosmetic and reconstructive surgery policy. Thank gosh. Anyone who's not on mute, please put yourself on mute. For transparency and per the CMS regulatory guidance, which is the Social Security Act, Section 1862, 1, Part D, and the updated IOM Program Integrity Manual, Chapter 13, which is post the Cures Act, all proposed drafts that we are presenting tonight were appropriately posted on the WPS portal as well as the CMS MCD portal. The open comment periods will begin on the dates that I had stated, and we will accept comments until July 14th and July 20th, respectively, for the proposed LCDs that I stated. For this meeting, the proposed LCDs will be presented in numerical order of the proposed drafts. The lead CMD for each proposed draft LCD will summarize the policy, and then we will open it up to oral public comments. Please note again that written comments, just to state this up front, please feel free to send in written comments. They are due, as again, I stated, July 24th and the 20th. Send your written comments to Medicare Policy Comments at WPSIC.com or the Policy Comments at WPS.com emails that Dr. Brady stated. Please note that when you include in your email the topic of the LCD that you'd like to give comments on, we ask that you include any other published scientific studies and or literature to support additional coverage with your message. We will not send individual responses to the comments. What we do is we make responses available in a comment and response document, which is also called response to comments, and that is posted with the final LCD. With that, I'd like to begin with the first draft LCD. Unfortunately, Dr. Campos cannot be available, thus she is the lead on this. So this policy, again, DL 39905 for cataract surgery. This is a new LCD. It is MAC initiated. It is a solo WPS LCD. There was no evidentiary meeting, and our lead is Claudia Campos. This LCD outlines limited coverage for cataract extraction procedures as described in the coverage indications of the policy. WPS coverage indications for cataract surgery are divided into three major categories. Number one, when visual function no longer satisfies patients' needs despite corrective lenses. Number two, when cataracts impede the visualization of the posterior segment of the eye during diagnosis or treatment. Number three, as prevention in cases of cataracts causing or coexisting with other intraocular pathologies resulting from the cataract. A comprehensive medical eye evaluation, the patient's consent, and anticipated refractory outcome must clearly be documented in the medical record. There are coverage limitations. Those include, number one, surgery is generally not performed in both eyes at the same time. Number two, complex capsular cataract extraction involves any extraordinary techniques and is not related to the surgeon's perception of the surgical difficulty. WPS's LCD is aligned with the best practices recommended by society guidelines based on systematic reviews such as the 2021 American Association of Ophthalmology Cataracts and the Adult Eye Preferred Practice Pattern. At this time, we will accept comments, any oral comments in regarding this draft. Rich, take it away.
Thank you. We have Dr. DiLorenzo who would like to make a comment. Go ahead.
Yes, good evening, everyone. So, yes, as Denise said, that in general, this proposed LCD does reflect current clinical guidelines supported by the American Academy of Ophthalmology's preferred practice pattern on cataract in the adult eye, published in 2021. We feel that WS should consider maybe revising some of the language related to same-day bilateral cataract surgery to bring this policy in closer alignment with current practice patterns. So indeed, while the Academy's PPP does state that same-day bilateral surgery is not commonly performed in the US, the PPP, preferred practice pattern, goes on to positively clarify that the potential patient benefits, emphasizing individual patient preferences, and making the decision for same-day bilateral surgery on the best interests for the individual patient's visual health and refractive status. So again, we just wanted to bring it in closer alignment with the current practice patterns, but otherwise it is it does reflect our guidelines.
Thank you so much, Dr. DiLorenzo.
All right, any other comments? Raised hand or unmute your phone. I see no other comments at this time.
Thank you, Rich. Okay, we will now go to our second draft, which is LCD DL 39907, microinvasive glaucoma surgery. This is a new LCD. It is MAC initiated. It is a collaborative, multi-jurisdictional proposed draft LCD. There has been an evidentiary contractor advisor committee meeting that was on January 5th, 2023. And our lead CMD is Dr. Juan Shaning, who will present a summary of this policy.
Thank you so much, Dr. Nasharsky. So this new LCD had an evidentiary meeting that was hosted by Palmetto, CGS, NGS, Noridian, and WPS. The input obtained from previous comments was taken into consideration in the development of the current proposed LCD, and the input of subject matter expert is referenced throughout this policy. This LCD allows one iStent Inject W or a Hydrus trabecular aqueous stent device per eye as medically reasonable and necessary for treatment of adults with mild or moderate open-angle glaucoma and a cataract when the individual is currently being treated with an ocular hypotensive medication and the procedure is being performed in conjunction with cataract surgery. In addition, the iStent Infinite device and the SEM45 subconjunctival space stent device are considered reasonable and necessary for glaucoma standalone procedures in whom previous medical or surgical treatment has failed. For cover indications, the number of stents allowed will be consistent with the stents contained within the device. The LCD considers one device per eye reasonable and medically necessary when used per cover indications. This proposed LCD was open to comments on May 30th, 2024, and the comment period will end on 7/14/2024. Now I would like to open the LCD for oral comments by our esteemed CAC members.
Dr. DiLorenzo, you may go ahead.
Thank you again. First of all, this is a thank you for the hard work done by the Contract Medical Director Work Group over the last year on this policy. I know you've been inundated with a lot of information, and overall, the current proposal does reflect current practice patterns and allows for the physician and patient to come to treatment decisions that work best for that unique patient. And the policy also recognizes the disproportionate disease burden of glaucoma on minorities, particularly African Americans and Latinos. So once, more research comes on combining multiple MIGS procedures with cataract surgery, I hope that the coverage can be extended to those Medicare beneficiaries who can benefit from it. So, but overall, we would like to thank you for the hard work done.
Mm. And regarding that, we really appreciated the input that we received from the American Academy of Ophthalmology. It was essential to making this the best evidence-based policy possible. And we have received comments, the excellent comments on the open meeting regarding small tweaks that are still necessary to the LCD that we are aware of, and we will address during the response to comment period. But I want to just give thanks to the society that the process worked, that their comments provided with references of literature were instrumental in helping the contractor to achieve their goal, that is they provide access to care to the best reasonable and necessary treatment supported by peer-reviewed published literature. So that's why we have these CAC meetings. That's why we have these interactions with the pertinent societies. So a big thank you from the work group because the input was instrumental in improving this LCD. With that has been said, I will open for additional comments on this LCD by any other of our STEAM CAC members.
I see no other raised hands at this time.
Okay, thank you very much. And Dr. Shaning, I'd like to echo all your comments in regards to our very actively involved and enthusiastic CAC members. For without them, we cannot write policy the way that we do without their expertise. So thank you very much. The next policy that we have tonight is DL 39909, botulinum toxin injections. This is a new LCD. It is MAC initiated. It is a collaborative, multi-jurisdictional proposed draft. There was an evidentiary CAC meeting on October 19th, 2023. And our lead CMD is Dr. Joelle Balakis, who will present her summary. Thank you.
And Dr. Vlahakis, before you present, we did receive a raised hand icon from Chris Wilson. So Chris, if you're able to unmute yourself.
Sorry, I jumped the gun. I just need to comment on this. I'll be quiet.
Okay.
We'll make you number one, Chris, for after this policy, okay? For jumping the gun.
Okay, and Dr. Vlahakis, I've sent a request to unmute your phone. I don't know how you hear that on your end.
Okay, can you hear me?
Yes, we can.
Perfect. I can follow directions. So our botulinum toxin collaborative multi-MAC LCD expands the number of covered diagnoses treated with botulinum toxin. The policy was written to be inclusive of a variety of disorders which now avail themselves to botulinum toxin treatment. Care was also taken to adhere to treatment guidelines, including toxin type, dosing, and frequency based upon the highest quality of evidence available. Botulinum toxin dosing must be used in accordance with the U.S. FDA approved labeling. For off-label botulinum toxin use without an FDA approved dosing indication, the qualified health professional must provide robust published clinical evidence to support the dosing use. The same is true for off-label Botox use without an FDA-approved serotype indication. For new FDA-approved indications for botulinum toxin serotype or dosing recommendations after the effective date of this policy, The qualified health professional must provide the updated published FDA prescribing information to support the use of botulinum toxin serotype or dose. Botulinum toxin administration must not be given more frequently than every 12 weeks, regardless of diagnosis, unless specifically addressed in the policy. The use of the toxin for all cosmetic procedures is not a covered benefit under Medicare. When botulinum toxin is used for an approved diagnosis, but the toxin is also being used with cosmetic intent, the entire claim for the botulinum is not considered reasonable and necessary. Specific indications and limitations of coverage are provided in each section for each diagnosis, including esophageal achalasia, anal fissure, blepharospasm, orofacial dystonia, cervical dystonia, chronic migraine, migraine headache prophylaxis, focal hand dystonia, hemifacial spasm, facial dystonia, hyperhidrosis, laryngeal dysphonia, neurogenic bladder, overactive bladder and urinary incontinence, sialorrhea, upper and lower limb spasticity, and strabismus. And I will stop there.
Thank you so very much, Dr. Vlahakis, for your very detailed summary. For the CAC members, at this time, we'll now take any oral comments regarding this draft.
Thank you. We'll hear from Chris Wilson first.
Hi, Chris Wilson, Neurology, Indiana. So I need to thank Dr. Vlahakis and the entire committee. This is a massive, incredible overhaul trying to get things put together into one document. It's challenging, right? There are some concerns that our Indiana Neurological Society have that we'd like to see kind of tweaked to improve patient care and access. And I think they kind of, I don't want to go through piece by piece because I know it's probably better to submit that into the written comments, email address, which some of our members already have done. But it really comes down to, I think, three things. One is there is this requirement for a lot of the indications to use research-based scales in routine clinical practice. Another issue is that there's some rigid dosing limitations for certain conditions. And, when the studies are done in a lot of neurological conditions, the N in the study is not very high. And a lot of patients with more severe conditions neurologically are excluded from studies. And so we have to remember when the medications FDA approved using certain dosing guidelines that this is not the entire population that we're treating, but just this is what was shown efficacious and safe in this particular study group. And then the other concern is there is a reduction in approved indications from the prior policies, like certain dystonia conditions, essential tremor, even spasticity is kind of missing if you read through it carefully. And, for instance, with the scale, some of these research scales take 5 to 15 minutes to complete. And if you think about access, there's not a lot of neurologists. We're all incredibly busy. And to add, an extra 15 minutes per patient to complete a research scale in a clinic appointment, not only maybe the first time, but some of the indications mentioned subsequent visits and follow-up would be exceedingly onerous and put a great burden on our neurologists and probably limit access even further to patients, which would lead to suboptimal outcomes. And one wants that for our patients. So it would be great if we could consider eliminating the required use of a lot of these research scales to justify treatment and retreatment. The lack of I guess you could say there's some clarity potentially as far as in some of the cervical dystonia indication, I believe, and I could have missed it, but I didn't see like Botox itself listed. I think there's Dysport and Mildblock, but I'm not sure that Botox was actually listed under cervical dystonia, and it does have an FDA indication for that. And I think it's probably just an oversight because this is such a huge undertaking. It's like you guys wrote a textbook on it, which is kind of cool in a nerdy way that neurologists like. But we just love to see it cleaned up. And so I'm glad to hear that this is kind of a working thing, and it sounds like there's going to be some tweaking done to it. And hopefully you guys can take the written comments that have been sent in already, and I'll send some more in. And I'd be happy to kind of at least, I have enough like committees and work, with my company, but this is a thing for a neurologist. And if you need a representative to help tweak this, I can help, or even put someone else in with the Indiana Neurological Society in contact with you guys for further improvement. So overall, it's a great undertaking, but gosh, we'd like to see it even better and clearer and less onerous so our patients can get access and have better outcomes. Thank you.
Thank you so much, Dr. Wilson. It is people like you, it is the physicians and the care providers out there that give us this insight, because we all know at the end of the day, what our primary goal is to take care of our beneficiaries, to give them the best peer-reviewed medical literature care, and to be able to have that available to many of our beneficiaries. So it is comments like you, from you, that is so vital to developing a great policy. So it was much appreciated.
Thank you. And Dr. DiLorenzo is next.
Thank you again. Again, thank you for your work group, and I echo Dr. Wilson's comments about the effort that is being put forth to get something together that is for the benefit of our beneficiaries. So we, as an American Academy of Ophthalmology, we have major concerns about this proposed LCD because this would, limit. It's sort of putting clinically infeasible criteria, treating blepharospasm with onabotulinum toxin A, Botox. And so specifically, I know this was mentioned yesterday in the open meeting, but specifically the LCD limits Botox injections to no more than 5 units per eye. And the number of injections for the initial treatment is limited to 3 per eye. And by doing that, it restricts the muscles into which these injections can be made based on an out-of-date FDA label. So we know that blepharospasm is a progressive and lifelong condition, and it renders patients functionally blind during episodes or, continuously. So it prevents them from performing their activities of daily living, like reading, driving, working, exercising, eating. And as ophthalmologists, we continuously monitor clinical reactions to our injections and potentially adjust the dose and the injection site and the type of botulinum toxin utilized in subsequent treatments. So sometimes, depending on the manifestation of the disease, a person with blepharospasm may require 6 or more injections per eye across the different eye muscles, the frontalis muscle, procerus, corrugator, and orbicularis. So injections of Botox to the orbicularis and these other muscles have been the standard of care for the treatment of blepharospasm for the last 40 years. So if this is finalized as written, medical coverage would be restricted to injection site and dosage amounts, which really are notably less than these widely regarded standards of care. So we strongly recommend that this is reconsidered and that we finalize a coverage policy which grants the physicians the flexibility to administer injections based on how the disease presents and to adjust subsequent treatments as necessary. So the treatment is based on patient response, not a predetermined dosage of medication. And
Thank you. And we have a comment from Dr. Al-Hassan El-Gauche. Forgive me if I don't pronounce your name right.
Yeah, this is Al-Hassan El-Gauche, Indiana. I also appreciate all the hard work that went into this. The salivary indications The information is very reasonable and sound, and I think in line with practice patterns. There are a couple of additional that weren't mentioned that I'd like to comment on, and I'll be happy to add some literature for these indications. One of them being sialosyl, or salivary fluid collection, and also salivary fistula. These can be traumatic and etiologenic, and toxin administration has been proved to be very effective in resolving these issues, which can be sometimes to treat. The indication is sialadenitis. That's not to other measures or even procedures such as endoscopy. And again, I'll be happy to submit some information supporting that. And just also for the record, I'm out to several laryngologists who practice in Indiana just to get their insight regarding specifically use in the larynx for vocal fold issues. Thank you.
Thank you.
so much. Oh, I'm so sorry, Rich. I stepped in front of you.
No, that's okay. We have another comment from Brad Orris.
Yeah, hi, Brad Orris. I'm a urologist in Indianapolis, speaking for myself with no disclosures. I guess would echo what Dr. Wilson said starting off. I appreciate the policy, but it doesn't exactly mirror what we always do in clinical practice. The FDA guidelines are somewhat outdated, and in particular regarding urology. Well, first of all, it says right up on the front under number 14 that anesthesia is not indicated for Botox. But if you look at the FDA labeling, it specifically says that sedation or general anesthesia should be, it says on the FDA here. FDA labeling says with or without sedation or general anesthesia may be used prior to injection. So the majority of my Botox patients we do in the office, but there are some who just can't tolerate it. I mean, it is a scope going into the bladder and injecting into the bladder, which I imagine is more painful than some of the other locations we're injecting it, and that's reflected in the FDA labeling. Also, some of our neurogenic patients have autonomic dysreflexia, which is safer to do them under an anesthetic. So for that reason, I think at least for cystoscopic injection, anesthesia should be available as needed. The dosing, or I guess what Dr. Wilson referred to as research scales and subsequent visits, that's another burden for us. If somebody's doing well on Botox in their bladder every 6 months, to bring them into the office at 4 months to tell me they're doing fine and make them fill out a scale doesn't make a lot of sense. It's just more of their time and more expense for the whole process. So I don't know that that's necessary. The dosing for neurogenic, we rarely go above 200, but occasionally we'll go to 300 units. We commonly, for overactive bladder, will go from 100 units up to 200, and this policy doesn't allow for titrating up to 200. So I would ask for some flexibility in the dosing for the bladder. That would be, I guess, my main comment. I do appreciate the inclusion of the interstitial cystitis painful bladder, because that is an off-label indication. So appreciate that inclusion in here. Oh, one other comment also. It seemed pretty rigid about the 12-week dosing. The concern I have with that is some of our neurogenic patients, or any patients, may be getting Botox in 2 different locations. I may be giving it in the bladder, and a neurologist may be giving it somewhere else. But when we submit claims within 12 weeks of one another, typically one of them will get denied. And so it limits their ability to get Botox in 2 different locations in that scenario. So I don't know if there's any way to amend the policy for going within the 12-week time frame if it's in 2, separate body locations. And I think that's the end of my comments. Thank you.
Thank you. And just a reminder to those of you on touch tone phones, if you press *3, that will give me the raised hand icon that lets me know you want to speak.
Thanks, Rich. And I just want to emphasize one more time here, because we've had such great comments from our CAC experts here, that please send your comments to the policycomments@wpsic.com and include the topic of the LCD on the email subject line. Again, I know many of you suggested that you would, but just please include published scientific studies and or literature to support additional coverage with your message. You have been giving us vital and important information. We just want to make sure that we receive it all from you in writing.
Thank you. And Dr. Don Seltzer has his hand raised.
Thank you. I am representing the American College of Surgeons Indiana chapter. I'm a general surgeon from Indiana. I'm asking regarding gastrointestinal applications of Botox. We certainly support the indications and the description of use for achalasia. I'm questioning whether or not this policy is meant to be an all-inclusive description of coverage of Botox utilization. The anal fissure and injection of Botox into the internal sphincter complex of the anal canal has been a long-term utilization, and it's not discussed here. So is that a separate policy, or is its omission suggest that it's no longer covered? And the second question I would have is, common utilization now is also to be used in the pylorus, and it's not described here either. I'm wondering if that is a separate LCD or if that is something that also means that it is not covered.
Thank you so much for your comments. Dr. Seltzer, I do believe, though, that anal fissure is described in the policy. But at any event, please send those comments in because we don't want to miss anything.
And this is Dr. Shannon. I want also to comment, that yes, my understanding is that anal fissure is addressed on the policy, but proposed LCDs are a work in progress. So it's very important that you submit in writing all the diagnosis and indications that you believe that we missed. This is a very voluminous document. So, in a read, something may be missed, but we depend on those written comments that let us know that, maybe a diagnosis that should be on our billing and coding article was missed, or an indication is not clearly addressed on the LCD. Those written comments from you as a subject matter expert are extremely important in our process of reviewing this LCD for finalization. So just wanted to request again that please send those things that you believe were missed in writing to us. Thank you.
And Dr. Northrop has his hand raised.
All right. Yes, thank you. This is Ben Northrop, CAC representative from Missouri. No conflicts or disclosures. One more comment on the indications for this. One that was missing that has really grown recently is Botox injections of the abdominal musculature, primarily the oblique musculature for patients with large ventral hernias. Sometimes the surgeons have a lot of difficulty with chronic ventral hernias with essentially getting the muscles to the point where they can be pulled back to midline, and doing these injections beforehand is very helpful in facilitating that surgery. If not, this can be a multi-part surgery, very difficult for the patient, very, very expensive. So it's really a useful procedure for that as well. I did not see that on the indications list. It is newer, so the evidence might not be quite as strong as what you have in the others, but there is evidence, and I can submit that in writing.
Great. Thank you all again who have participated. With no other comments in regards to that policy, we will now proceed On to the next draft, which is DL 39911, total joint arthroplasty. This is a new LCD. It is MAC initiated. It is a solo WPS LCD. There was no there was no evidentiary meeting required. Our lead CMD is Dr. Joelle Vlahakis.
All right, so we combine both hip and knee arthroplasty for this LCD. The reason for needing hip or joint replacements or knee replacements vary, but are typically related to degeneration from osteoarthritis, rheumatoid arthritis, or trauma. Guidelines for performing these procedures have been published by the American Academy of Orthopedic Surgeons, the American College of Rheumatology, and the American Association of Hip and Knee Surgeons, and other very reliable sources. These guidelines and recommendations have been critiqued, considered, and consolidated in this local coverage determination. Total knee arthroplasty will be considered medically necessary when one or more of the following criteria are met: failure of previous osteotomy, or distal femur fracture, or proximal tibial fracture, or malignancy of the distal femur, proximal tibia, knee joint, or adjacent soft tissues, or failure of previous osteotomy, or avascular necrosis of the knee, or advanced joint disease demonstrated by all of the following: radiographic supported evidence, and I won't list everything here, but it's elucidated in the LCD, pain or functional disability attributable to the advanced joint disease, and history of failed conservative therapy, which is clinically appropriate for the patient's current episode of care. And we've listed several examples of both unsupervised exercise and supervised physical therapy programs. Other things to consider are replacement or revision of a previous total knee replacement or total knee arthroplasty, and that would happen due to a disabling pain or functional disability, progressive or substantial periprosthetic bone loss, or fracture or mechanical failure of one or more of the components, an infection, aseptic loosening of one or more of the components, failure and wear of the prosthetic components leading to symptomatic synovitis, or implant or knee misalignment, or extensor mechanism instability, or knee stiffness, arthrofibrosis. I'll move on to total hip replacement surgery, which will be considered medically necessary when one or more of the following criteria are met. These mirror our total knee replacement: malignancy of the joint involving the bones or soft tissues of the pelvis or proximal femur, avascular necrosis or fracture of the femoral neck, acetabular fracture, non-union or failure of previous hip fracture surgery, or malunion of acetabular or proximal femur fracture. Advanced joint disease is evidenced by all of the following: radiographic or MRI evidence supporting advanced joint disease, and pain or functional disability attributable to the advanced joint disease, and history of failed conservative therapy appropriate for the patient's current episode of care. And we list that out, including both supervised and unsupervised activities. And then, of course, replacement or revision of the total hip replacement can occur when instability of one or both components is present, or fracture or mechanical failure of the implant, or recurrent or irreducible dislocation, infection, or clinically significant leg length inequality not amenable to conservative management, or treatment of a displacement periprosthetic fracture, or progressive or substantial bone loss, or clinically significant audible noise or adverse local tissue reaction. And I'll stop there.
Thank you again, Dr. Vlahakis, for this detailed summary for our members. At this time, we'll take any oral comments regarding this proposed LCD.
Just a reminder, click the raised hand icon or press *3 on your touch-tone phones. And I see no comments from the CAC members on this proposed LCD.
Thank you so much, Rich. So let's proceed on with our next one. It is DL 39913, Artificial Intelligence or AI enabled CT-based quantitative coronary topography, that's AI-QCT, and coronary plaque analysis, AI-CPA. So that was a mouthful just in that, okay? This is a new LCD. It is a stakeholder request. It is a collaborative, multi-jurisdictional proposed draft LCD. There was an evidentiary contractor advisor committee meeting with subject matter experts on May 25th, 2023, and the lead CMD is myself. So a summary of this is this policy, as I said, was based on a stakeholder LCD request for coverage for quantitative coronary plaque analysis using AI. The coverage indications, limitations, and or medical necessity is that this AI-QCT / AI-QCPA, all right, is using coronary computer tomography angiography or CCTA, is considered reasonable and medically necessary as a diagnostic study when, number one, the patient is eligible for CCTA, and number two, the patient presents with acute chest pain and no known CAD, as defined by the 2021 multi-societal guidelines for the evaluation and diagnosis of chest pain, and is classified as one or both an intermediate risk patient or a CAD RADS2 and RADS3 category on CCTA, and also the cardiac evaluation is negative or inconclusive for acute coronary syndrome. The limitations of this policy include that it would not be considered reasonable or necessary in the following clinical circumstances. Number one, the test is never covered just for screening, that is in the absence of signs, symptoms, or disease. There is no number two, there's no contraindication to obtaining a CCTA. Number three, not in conjunction with invasive coronary catheterization. Number four, not to be used with normal CCTA results, that is a CAD RAD0 or no plaque disease. Number five, not to be used with high-grade stenosis, meaning greater than 70% or a CAD RADS category 4 and 5. Not allowed if you've had a recent myocardial infarction, 30 days or less. Number seven would be unstable coronary symptoms. And lastly, it is not to be used for surveillance. So at this time, we'll take any oral comments regarding this draft.
We have a comment from Dr. Ben Northrup.
All right, thank you, Denise and Richard. Ben Northrup, CAC representative, Missouri, no disclosures. So first off, we'd like to thank WPS and the other involved MACs for issuing this coverage decision. We agree with the vast majority of what's in here. We just had a few comments in terms of ways to strengthen this proposed LCD before we finalize the content. So, and I will submit this in writing too, or our association will, with associated references. Okay, so first off, in 2021, the ACC and AHA chest pain guidelines, as well as CAD-RADS 2.0, both highlight the importance of assessing atherosclerotic plaque burden in both acute and in stable chest pain. This significantly influences the management and the prognosis of coronary artery disease. So we recommend adding that in as well. Additionally, the Scott Hart trial published in Lancet in 2015 demonstrated that incorporating CCTA into the standard of care that is, improves diagnostic certainty and patient outcomes. So we want to include those patients with stable chest pain for AI-QCT analysis to ensure adherence to the most recent evidence-based guidelines. Also, to fully align with the studies I mentioned before, the 2021 ACC AHA chest pain guidelines, as well as CAD-RADS 2.0, it's crucial to include those patients with stable chest pain. We have 2A recommendations for that, and we'll include those studies as well. And then finally, the 2018 version of the Scott Hart trial demonstrated that incorporating CCTA as part of our routine care significantly reduces morbidity and mortality and improves diagnostic accuracy in stable chest pain patients. So yet again, another point showing that the use of this in stable chest pain patients, not just those that are symptomatic or have unstable chest pain, is very important diagnostically and for management. And yeah, there's a few more things we can mention, but I'll just put those in the written comments. Those are kind of the main points. And if you have any questions, let me know.
Thank you so very much, Dr. Northrup. Very much appreciated and very much recognize that need for placing that word stable chest pain. And as Dr. Shaning has stated in the, this is proposed going to final. Your comments are great. They are really acknowledged, and we'll proceed from there. Again, putting them in writing will be greatly appreciated for us.
Any other commenters? Press the *3 or the raised hand icon, and I will call on you. Okay, there are no comments at this time.
Thank you, Rich. All right, our final draft is 39051, cosmetic and reconstructive surgery. This is an existing LCD. It is WPS MAC initiated for a revision update. There is no evidentiary meeting required. Our lead CMD is Dr. Joelle Vlahakis in regards to this.
All right, so I know you guys will be very sad to know that it's a short one. So this really is specific to a portion in the section on abdominal lipectomy, paniculectomy only. The most important clarification is that paniculectomy will be considered medically necessary when the pannus or panniculus hangs below the level of the pubis and one or more of the following conditions are also present: chronic intertrigo, difficulty walking or functional impairment of activities of daily living, and if the procedure being performed is following significant weight loss. In addition to meeting the criteria, there should be evidence that the patient has maintained a stable weight for at least 6 months. And for patients whose weight loss is the result of bariatric surgery, paniculectomy should not be performed until at least 18 months after bariatric surgery and only when weight has been stable for at least the most recent 6 months. And I'll stop there.
Oh my, Dr. Vlahakis, I was still giving you a few more minutes. Now, I wanted to discuss this. At this point, do we have any oral comments in regards to this revision update?
There are no raised hands at this time.
All right, thank you so very much, Rich. This will actually, at this point, all 6 drafts have been presented with allocated time for public comments. Again, just one more last push I'm going to put in there. Please put in writing any comments that all the presenters are, all of our CAC specialists who made comments tonight. One more time, if it's not, I do see it's still up there. So it's at the policy comments at WPS.com. If you could put in writing for us, and we will have these addressed and provided in our response to comments with the final draft. So it is much, much appreciated. So at this point, we will end the open portion of this combined J5, J8 CAC meeting and proceed with the education portion of this CAC meeting. So, Rich, if you could please close the line so the public would be greatly appreciated.